Thank you very much. Thank you. So we're just going to talk about corneal disease, and then we're going to talk about glaucoma, because I think those are things that you genuinely see in practice as emergencies. I think ulcerative keratitis you all see all the time. So we're going to talk about approach to ulcerative keratitis and things you presumably are doing and can do in practice, and then the things that potentially you might have to refer. The cornea obviously is the clear structure at the front of the eye that's contiguous with the sclera. It's only 0.5 millimeter thick, so you don't have a lot of tissue to work with, which means that if you get an ulcer that's more than just superficial, i.e. just in the epithelial layers, you can get extension of the ulcer quite quickly, and we know that in brachycephalic dogs particularly, they can melt and perforate within 24 to 48 hours. So if you're seeing brachyes regularly, and I presume you are like we are, then you need to be treating them aggressively and treating them early. And now the thing's not working. There you go. So this is one of John Moll's fantastic slides, just showing you the proximity of the cornea to the sclera, and the fact that obviously having gone through the cornea, you're straight into aqueous. As soon as you get a perforation, then you get aqueous rushing forward and you get the iris plugging the hole, and we'll talk a bit about that. The problem with the cornea is that it's nourished mostly by the tear film and to a smaller degree by aqueous. It doesn't have its own blood supply, and so therefore it's got a poor healing response. And as I say, it is particularly thin, especially in the center, where it's only about 0.5 millimeter thick, which is the same depth as a credit card. So when you're displaying that to people and you're trying to work out or explain to them why it's such a big deal to treat these ulcers rapidly and aggressively, it's always quite a good idea, I think, just to show them in real terms what goes on. The cornea is protected by the eyelids, and so lots of things that you and I see on a regular basis that may abrade the cornea, including ingrowing hairs, so dystechia, ectopic cilia, and entropion are obviously part of the picture. The other thing is that the tear film is the other bit of it, and if you're talking to Dome tonight, then you'll know that there's lots of products out now to try and supplement the tear film. The tear film is in 3 phases, so it's everybody knows about the qualitative tear film issues and the fact that dry eye is in most places an autoimmune disease, and that it responds normally reasonably well to cyclosporin. But what we don't talk about is that there's a qualitative dry eye as well, which is where you have either lack of lipid or lack of meibomian secretion, so mucus. So you understand that the meibomian glands are in the eyelid margin, so here and here, and that's where those dystechia tend to exit from. But the goblet cells are the ones that produce the mucus layer, and that's produced on the lining of your conjunctiva. So, and you need both. And there's actually a really good bit from Dome at the moment talking about measurement of tear film from the point of doing Schirmer tear tests, but also there's something about doing tear film breakup times. And if you can all learn to do them, it's a really, really good thing to do. Because often you'll see dogs that present, with a dry eye picture, even though their Schirmer tear tests appear normal. And what lots of people don't then go to do is do a tear film breakup time, which is a really easy test to do. And actually, if you take the little leaflet from Dome tonight, it's got not only a sort of step-by-step guide of how to do it, but it's also got a video as well. So you can follow the link and actually have a look at the video. So it really is worthwhile picking it up tonight. When we think about the cornea is obviously in several layers. The outer layer is the epithelial layer, which is about 9 to 12 layers thick, and then underneath that is all stroma. So the vast majority of your cornea is stroma, and then at the very bottom, this faint pink line is Descemet's membrane, and then inside that is the endothelial cells. So epithelial breach obviously is where the corneal ulcer starts, and that usually is response to trauma, especially in dogs. In cats, we know that a lot of corneal ulcers are secondary to feline herpes virus 1. So feline herpes virus 1 is epitheliotoxic. It loves epithelial cells, be they conjunctival or corneal cells, and it lyses those cells really readily. The problem is that once you get into stroma, which is the vast majority of the cornea here, there's very little to protect the cornea from digestion. And so as soon as bacteria get in here, especially Pseudomonas and beta hemolytic streptococci, they produce proteases which digest this proteinaceous material really quick, which is why you can get to perforation within 24 to 48 hours. The other thing that's a bit irritating about corneas is that all of the innervation for your cornea is usually just in the anterior stromal layers and just at the basement membrane and first part of your epithelium. So what that means is that the painful ulcers tend to be the ulcers that are really shallow, and as the ulcer gets deeper, often the clinical picture is that the dog is improving. In other words, there's less pain associated with the ulcer. So just because your dog's got an ulcer that's getting apparently better because the eye's open and appears less painful, that doesn't necessarily mean that the ulcer's not getting deeper. And we know that the brachycephalic dogs have got a poorer innervation on their cornea anyway. So when you look at the mapping of the nerve cells on the cornea of brachycephalics, they're much more sparse. So they don't have a particularly good innervation to begin with, which means they're much more likely to traumatize their globe. And when they do get traumatized, they're less likely to respond by increasing their tearing and by protecting their eye by closing their eyelid. Gosh, it's really not. There you go. So if you look at it in more detail, this is the epithelial layer here, and as you can see that they start out as columnar cells and become squames, and then they're shed, and that happens every 7 to 10 days. So we know that in a normal healing response, if you just get a superficial ulcer and it's uncomplicated, that it should heal within 7 days. And these cells are really actively dividing very rapidly, so there should be little or no reason why they shouldn't do that. And you understand that the corneal healing comes from the limbal layer, so that's at the edge of the cornea, and then they slide in the way. So and they move about 1 millimeter a day, between 1 to 2 days, so that you expect, as I say, even in a big defect, they should have been able to move across the sort of 14 or 15 millimeters of the central cornea within a week. The base layer at the other end of the cornea, so this is stroma here, and then this is Descemet's membrane here, and then this is this single cell layer, which is the endothelial layer. And as soon as you get down here, as soon as you get to Descemet's membrane, so these are these very deep ulcers that don't stain with fluorescein, that is 22 microns thick, which is 7 red blood cells. So when you get to Descemet's membrane, one sneeze and that ruptures, and your dog is at real risk of losing its eye altogether. So it's really important that as far as possible, you don't allow the protease to start, and you don't allow the deepening of these ulcers, because if you do, the chance of saving them is much poorer, and we know that if they're infected with, especially with Pseudomonas, that up to 50% of them end in perforation. So it's really important that you treat early, that you treat aggressively, and that you get them back for regular rechecks, which means every 1 to 2 days if it's a brachycephalic. If we just talk about the precorneal tear film just a little bit more, the outer layer is the lipid layer, which is the one that's produced by the meibomian glands, and that's the one that stops evaporation. So that's the gland on the eyelid edge that you can see as little white dots, and the one where you'll see where the distichia tend to exit from. The middle layer is the aqueous layer, which we all know about, which is the one that's produced by the lacrimal gland. The majority is produced by the lacrimal gland, but the nictitating gland can add up to 40% of the tear film. So if you're thinking about chopping out a cherry eye, try not to do that, because that's a really good way of adding to your dry eye picture, especially in the dogs that tend to be predisposed, like the kind of English bulldog, which is the classic dog to get the cherry eye, but it's also a classic dog to get dry eye as well. So please try not to cut your cherry eyes out and put them back into a conjunctival pocket instead. And then the inner layer is the mucus layer, which is the one that's produced by the conjunctival goblet cells, and it's really involved in kind of trying to stop the shearing effect as the tear film rolls over the top of the corneal surface. But the honest truth is that they're not in 3 layers. They're all mixed in together, but the lipid tends to go to the surface and the mucus tends to sink to the bottom. As I said earlier, it is really important not just to do your Schirmer tear test, but also to do your tear film breakup time. So, as I say, grab one of those sheets if you can and have a look at it, because it's a really good way of working out whether your dog has got a qualitative issue. And we know that, again, the brachy's often have quite good tear production, so we'll see quantitative tear production levels, especially in the French Bulldogs, being pretty high, so 15 to 20 at least. But when we do their tear film breakup time, you'll see that you'll get the fluorescein splitting after sort of 5 to 10 seconds. And classically, when you do your tear film breakup time, you want the fluorescein to remain stable on the corneal surface for 20 seconds or above. So you literally just put the fluorescein on, open the eyelids, and then hold it there with preferably with a blue light. So if you've got a blue filter on your ophthalmoscope, even better. And then you're counting, so you're waiting to see whether or not you get 20 seconds of a stable tear film or not. I really can't get this to work. There you go. Corneal ulcers. So we know in normal conditions that corneal epithelium will heal in 7 days, and therefore all ulcers we expect to be healed within 7 days. So you see the dog or cat, they come in, you give them pain relief, you give them some sort of artificial tear substitute, preferably something like Remend or something like that that's got a high hyaluronic acid containing content, and you give them all antibiotics. So all of the corneal ulcers get antibiotics, enough to use first-line antibiotics, so chloramphenicol is fine. There's no isothal at the moment, to be fair, but certainly chloramphenicol is more than enough. What we do know is that any ulcer that takes more than 7 days has a complicating factor. And so all of your ulcers need to be rechecked again in 5 to 7 days. If it's a brachycephalic, as I say, I think you need to check them earlier. And then you start to look for underlying conditions. So the top of the list for corneal ulcers is dry eye. So that's when you're going to do your Schirmer tear test and preferably do your tear film breakup time. And you're going to check the eyelid margins using your direct ophthalmoscope, or if you've got a slit lamp, even better. So you're going to turn your direct ophthalmoscope round to +20, which is where you're allowed to, that's the really easy way to look at eyelid margins. So turn it round to the +20, so black 20 on your ophthalmoscope, and have a look at the eyelid margin for ingrowing hairs. It's a really good way of looking at them, and if you don't have a slit lamp, then it's almost as good. And we know that if the epithelium does get breached, that the proteolytic destruction of the stroma begins pretty early. And it's not just the fact that you can get exogenous protease activity, so that means bacteria and fungi, so for us that's Pseudomonas or beta hemolytic streptococci. It's also the fact you get endogenous destruction as well. So neutrophils that are dying produce proteolytic enzymes, so do dying keratocytes, and so the melting process starts. And when the melting process starts, it's an imbalance between the healing response and the amount of protease activity. And as I say, that's what normally leads to perforations. And we know that when we swab these eyes, quite a few of them come back with no bacteria at all, but they still continue to melt, which is why you need antiprotease activity. And that's what we're going to talk about in a minute. So most corneal ulcers are caused by trauma. We know that, especially in dogs, definitely caused by trichiasis and occasionally foreign bodies. Dry eye, we know, will definitely lead to an increased risk of corneal ulceration, but usually you have to have trauma first. There are some inherent corneal defects as well, like corneal dystrophies, and we're going to talk a little bit about one, the basement membrane one, in a minute, to do with boxer ulcers or indolent ulcers. And then conformation, obviously. So for brachycephalics, the problem is that they've got everything. They've got a macropalpebral fissure, so their eyelid is too long for their eye, which means that when they blink, they don't actually close their eyelid fully, and the tear film splits in the middle. They often have medial entropion, especially on the ventral margin, so they've got hairs rubbing on their eyes. They tend to have poor nerve innervation, as I say, of the corneal surface, so they're more likely to get trauma in the first place. And then just to kind of complicate matters, and especially in cats, feline herpes virus 1 is massively important. So if you're seeing a cat that has had no previous history of trauma, then feline herpes virus 1 should be top of your list of suspicions for the cause of corneal ulceration. Diagnosis of corneal ulcers you all know about, so fluorescein is your friend, so any red eye should get fluorescein done. If you're going to use fluorescein, obviously you're going to use it after you've checked the tear films. You're going to do your Schirmer tear tests and your tear film breakup times first. And you understand that it won't, it's lipophobic, so it's those fat-rich epithelial cells will repel or not be stained anyway by the fluorescein, whereas stroma will stain very nicely with fluorescein. And interestingly, Dome have just brought out a 0.5% fluorescein. We use 1%, which is the minimum one that probably most of us use. But there are definitely dogs that object to having fluorescein put in, the 1%, and I noticed that yours is 0.5%. So I wonder if that might be a way forward for us, actually, is to use a less concentrated solution. The great thing about it is that it lasts for 2 or 3 hours, so if you put it in and then flush it out with some fluorescein, you're not going to miss the ulcer because it'll adhere to any exposed stroma, so there's no chance you're going to miss the ulcer. And you know that if you use a blue light, it excites the fluorescein. So if you drop the lights, turn on a blue light and look for fluorescein, you can see it, and that's really useful when you're looking for very fine dendritic ulcers, especially in cats, or little punctate ulcers that you get in things like dachshunds that have punctate keratopathy. And the massive thing, and you all know this because you've been in practice for long enough, is that it does not stain Descemet's membrane. So if you ever see a steep-sided ulcer that is green down the sides but is clear in the middle, that's you down to Descemet's membrane. That's an absolute emergency. So that is what are we going to do? So, and that's a surgical option. It's not you're long past giving proteases or anything else. So you're either going to do some corneal surgery or you're going to get Tony out of his bed and he can do his corneal surgery. Diagnosis of corneal ulcer, plenty, this is self-explanatory. Some of this is done for the undergraduates, but just this idea that it's not always possible when you look at a red eye to see whether or not there's a corneal ulcer there or not, but as soon as you put a fluorescein dye on the corneal ulcer, it will stain, and not only will it stain the ulcer itself, but it will tell you whether or not there's any suggestion that the epithelial edge is underrun. So you'll get 2 colors of fluorescein. So you can't really see it in this light, but there's a brighter green color in the middle. But this is one of these indolent ulcers because it's got a darker green edge to it, and that's because the fluorescein is actually starting to seep out underneath the epithelial edge because the epithelial edge is not adherent. And for those ulcers, it's not enough to give antibiotics and painkillers and some sort of artificial tear supplement. Those are the ones that you have to debride as well. So when you're thinking about treating corneal ulcers, you're obviously going to try and establish a cause, but sometimes that's very difficult to do, but you suspect that most of them are trauma. First-line antibiotics would be isothal or chloramphenicol, unless you think it's already starting to melt, in which case you need to go straight to something much bigger, and usually that would be Exocin. So I presume you all have Exocin in your practice, so you know what to do with that. Siloxane would do just as well. And you do need to start some sort of pain control. And that usually means systemic non-steroidals. And the reason you want to do that is because, not least just from the point of view of the welfare of the patient, but if you don't control that, then what happens is that you get iris spasm, so you'll start to see a secondary uveitis, which is really hard to control and so increases the pain. And you'll also see that the eyelid margins are much more likely to start rolling in the way because you get enophthalmos. The eye pulls back when it's painful, and that encourages the eyelids to flip in the way, which means you're going to get more abrading of the corneal surface with the eyelashes and with any hairs that happen to be there. We really like artificial tear gel. I presume you all use it. It makes a massive difference. It's a great way of supporting the tear film. You want that tear film in place because those epithelial cells are much more likely to migrate across the surface if there's a stable tear film in place. So it is important to add that into your first-line treatment. And if it is a superficial ulcer that is underrun, then you need to debride at the first consultation. It's not enough simply to send them home with isothal and Metacam and some artificial tears and hope that somehow that epithelial edge that's underrun is magically going to readhere itself to the underlying basement membrane, because it's not going to do that. So you need to get some dry cotton buds and some betadine solution and go ahead and debride it the first time. We do use atropine for some of them, especially if they've got a myotic pupil. So if you look at them and there's a discrepancy between the 2 pupil sizes, we tend to give them atropine as a one-off, so 1 drop, and then not send them away with it. The reason we don't send them away with atropine is because it dries your tear film. So you're sometimes creating more problems for yourself than you're solving. But a one drop of atropine is perfect, which is why having those little boxes of minimum atropines work really well. And if you do have any suspicion that they are starting to melt, then obviously you're going to start antiproteolytic medication as well. And we're just about to talk about that. So when you think about treatment of corneal ulcers, you want to obviously correct the underlying cause, and sometimes that means putting in temporary tacking sutures. So do you do that at all if you see puppies and stuff with ulcers? So you just sedate them and put in temporary tacking sutures, which are just inverting sutures to roll out those hairs that might be rubbing on the eye. If you do see one that's on the run, then you're going to debride it. We give antibiotics to all ulcers. There's not a case when we don't give antibiotics to, and it's not because they're necessarily infected and that's what's caused the ulcer, but because we know that if you don't do that, the colonization of, given that staph and streps live in your conjunctival fornix and are in your tear film all the time, they will colonize those ulcers really quickly. So it's really important that they do get antibiotics. I know some people aren't very keen on giving antibiotics for ulcers at the beginning, but I don't think you can, in dogs especially, you can't. That doesn't work. We'll get back to the other bits in a minute. The only other thing I would say is, and you know this all, is that do not use third eyelid flaps in deep ulcers, because it's absolutely asking for trouble. John Mould, do any of you remember John Mould that used to be at Glasgow? Yeah. He did a really good set of papers on people who've done third eyelid flaps. And so these were dogs that were eyes anyway that were sent to him. And the number of perforations under a third eyelid flap for a deep ulcer was about 80%. So he was saying that really for superficial ulcers you might think about it, but not for deeper ones. Things you don't do for corneal ulcers, you don't use topical corticosteroids, you all know that, and you don't use topical non-steroidals either. So you can still get a melt with a topical non-steroidal, so if you were thinking about using Ocufen or Acular or Yelox because you thought that might help with the pain of an ulcer, please don't do it, because actually it'll add to your or increase your chance of getting a melt. You don't debride melting ulcers, so if you see a brachy that's got an ulcer that you're not sure about and has that indistinct yellow edge, then please don't debride them, because we know that adds to the melt. So the ones that you are going to do are the classic dogs like the Staffordshire Bull Terriers that get the superficial indolent ulcers. And don't use multiple doses of topical local anesthetic in place of adequate pain relief, because we know that certainly proximeticaine is epitheliotoxic, so if you use it more than once at the time, you're actually adding to the corneal epithelial cell death. And the other thing, and you all know this, is don't do a grid in a cat. You all know that, don't you? So if you ever see an indolent ulcer in a cat, which is usually secondary herpes virus, you would never do a grid, because that's a very good way of creating a sequestrum. So please don't do that. If you're thinking about unusual or active treatments for, yes?
Just a quick question. You said don't use third eyelid flap in deep ulcers.
Yeah.
Are you saying those ulcers where you can see a halo first with desmoid, or are you just talking about it looks deep from?
Yeah, I think. Yeah, that's a good question, isn't it? I think personally we don't use third eyelid flaps at all, because I don't like them. I don't like them because I can't see what's going on. And I think that's what I don't like about them. We know that if they're down past 0.2 of a millimeter of the corneal surface, then they're much more likely to start melting. And there's quite a lot of evidence that just covering it with third eyelid flap, all you're doing is you're just trapping the infection in there, and the protease activity keeps going. I'm trying to think of a. I suppose you could use them potentially, I suppose, in a superficial ulcer that you're convinced only has an underrun edge. But there's lots of other treatments that are much better than that, and we're about to talk about that. But I don't, unless you feel otherwise, but I don't. I think nowadays there's too many other good options rather than using a third eyelid flap. So we'll talk about them first, and then you can come back. I'm happy with that. If we're talking about specific treatments, I cut quite a lot of this talk out because it was going to run for too long. So if you're talking about feline herpes virus, you all know about using Virgan, don't you? Is that right? So ganciclovir is the way forward now if you're doing feline herpes virus. So you see a cat that's got an ulcer, especially if it's got a dendritic ulcer. So rather than just the normal treatments where we're talking about topical antibiotics, topical artificial tear supplements and pain relief, if you see a cat with what looks like a herpes virus ulcer, then you should be reaching for Virgan, which is ganciclovir, and it's just 4 times a day into the eye. And actually that makes a massive difference to these cats, and they often resolve really quickly. In the past, we had to use things like trifluorothymidine, which was much more expensive, and nipped like fury when you put it in, whereas this is actually doesn't nip, only has to go in 4 times a day, and trifluorothymidine was about £100, whereas this is about 25. So if you can get hold of some, it's worth having one on the shelf. The other thing with cat ulcers is it's really good to use artificial tear supplements. So Remend is really good, as is Anhypro, because a lot of these cats have a qualitative tear film issue. So it's worth, if you're not doing that already, to make sure that that's on your list. I would, because I tend to give them that on, because I'm worried about the fact they're going to secondarily bacterially infected. So we tend to give them a chloramphenicol too. If we think about the sked ulcers just for a minute, then we know that those are the non-healing ulcers which are superficial and underrun. So you know, because you've got that epithelial edge which is non-adherent, and you can see it because when you do your fluorescein staining, you can see that there's 2 colors of fluorescein. You know that it's superficial because you've used your direct ophthalmoscope, and in quite a lot of the direct ophthalmoscopes now there's a slit function, so you can actually turn it onto the slit, which is the vertical white light, and as a result of that you can actually gauge the depth of the ulcer by passing the white light down the front of the cornea. We don't really know what happens and why they happen in certain breeds, but we do know that the migrating epithelial cells can't adhere to the underlying basement membrane. They can't put down these little anchoring fibrils. And it used to be thought that it was only in boxers, but now it appears that it happens in a number of breeds, including Staffordshire Bull Terriers and Border Collies, but it can really happen in any older dog. And if you see a sked ulcer, which is the other name for an indolent ulcer, then you need to debride it from the get-go. So this is a sked ulcer in a boxer, and you can tell it's a sked because it's got that epithelial edge there that is underrun, so it appears as a white thickened halo on the front of the cornea. You know it's not particularly deep because when you run the white light across it, it's all in the same plane. So it's not like you're starting to see a crater on the front of the eye as you would with a melting ulcer. This is another one, and this is still a sked ulcer, even though it's got quite a lot of vascularization. So this neovascularization started, but again, you can see that it's got this thickened white edge all the way around. So sked ulcers, initial treatment would be debridement, so that's happy for all of us because it's nice and easy to do. So cotton buds, so and you're supposed to do dry, wet. So 1 dry followed by 1 wet, and the wet is betadine antiseptic. So you all know that. I'm sure you've all got iodine antiseptic in your practice. It's a 1 in 50 dilution because the idea is that it's not going to be caustic, you just make sure that nobody has, by mistake, ordered betadine surgical scrub, which has got soap in it, which is a really good way of taking up all the epithelium. So, and it happened to us in our practice, SVR, another practice, and not that long ago. And it just shows how easily it's done. So we've ordered betadine for years and years and years, and I think there was a bit of an issue with getting it, so they got it from something else, from somewhere else, and it turned out to be a betadine scrub, not antiseptic, which is a fantastically good way of doing a debridement, even if you didn't mean to. So you know to do that, you do it, so we tend to do it 4 or 5 times. You do it in a sort of centripetal fashion, and the idea is that you just sweep off all that corneal epithelium. Only non-adherent corneal epithelium will come off. So it's not as if you're going to take intact epithelial cells off. You can't take them off just using cotton buds. So it's a very safe thing to do. It's usually really well tolerated just in the consulting room using some proximeticaine, and you can do it twice, 7 to 10 days apart. So we use plenty of local anesthetic to begin with, so just some proximeticaine, usually 2 sets, 60 seconds apart. Use firm pressure. And then just work your way outwards in concentric circles until you've got off as much as you can. And then they're home with their antibiotics and their artificial teardrops and their pain relief. And then you see them back again in 7 to 10 days, and if it's not healed, then you can do the same thing again. If that doesn't work, then you've got to make a choice between doing a grid keratotomy, which is where you use a very fine needle and create a grid pattern on the corneal surface. And this is one that was done using you can bend the 25 gauge needle so that it's much easier to do. And then you create a very, very fine grid pattern on the surface of the eye. The idea is that you just see it and no more. And the idea is that having created these tiny furrows on the corneal surface, the epithelial cells can then hang on to them and move their way across. But probably what you might think about doing instead of that, so you can do that with heavy sedation or a local anesthetic. So you would still debride the edges first, and then you'd use the 25 gauge needle, or what's even better is to use an insulin needle because it's a 30 gauge needle. And just create this tiny grid pattern. You need to make sure that it overlaps the edge of the ulcer, otherwise the ulcer won't heal, but as long as you do that, you're fine. And obviously you don't do it in cats because you'll get a sequestrum. But the other thing that really works is the algae brush. So have you all got algae brushes? Yes? No? Okay, because it's definitely worth getting. So they're very easy to use. It's a very simple way of dealing with a sced ulcer. They're cheap to buy. They're super safe. That's the great thing about them. And then the idea is that you would use that for your sced ulcer. So you would literally debride it with your cotton buds again under sedation, and then use the diamond burr just to gently just burr off all those loose epithelial cells. And then what we classically do is put a contact lens on them and partially shut the aperture, the eyelid aperture. But if you don't want to do that, then as I say, you can do a grid, but just be careful that you do the grid really, really lightly. We had one in Fife about 6 months ago that was done for some reason with a 21 gauge needle. I don't know why they thought that was a good idea, but they did, and it led to a perforation. So whoever did the grid actually went straight through the cornea, so it had to be sutured. Having done that, your diamond burr should work. So supposed to be 70% of ulcers heal with a cotton bud debridement. 90% of ulcers heal with a diamond burr. And if that's not enough, they have to get a superficial keratectomy, which is, again, something that's done under an operating microscope. So it's a bit more involved, to be fair. And then if we think the other end of the spectrum, we think about melting ulcers. And if we think about melting ulcers, we think about brachycephalic. So this is the Friday afternoon pug that's seen that is just the kind of bread and butter of ophthalmology. Unfortunately, it's a bit sad, but it's true. So you can see the melt in this eye. This is just a very sad-looking pug who apparently had only had it for a few days, but you can see, how much of that cornea is affected by that melt. So these are melting ulcers. You know they're melting because they have that horrible proteinaceous discharge. The surface of the cornea becomes gelatinous looking, and the edge of the ulcer becomes very amorphous, which means it's really difficult to work out exactly where it is. You'll often start to see a sort of darkening in the center of the ulcer. So as the ulcer gets deeper and the edema is obviously forming around the edges, where it starts to get super thin, it often gets very dark, and really what you're looking at there is just the pupil starting to stare back at you through the really thin epithelium. And in fact, that one is that probably would be down to Descemet's membrane just there. So it happens, as I said, because there's an imbalance between the proteolytic enzymes and the healing action of the cornea. They're produced by the dying white blood cells, but also by the bacteria. Pseudomonas are the ones that we fear the most, but also beta hemolytic streptococci. The problem is that the exocin, which is the drug of choice for any sort of melting ulcers, is very good at killing Pseudomonas at the moment, so we're delighted about that. But there are cases now where beta hemolytic streptococci are resistant to it. So, and just to really make our lives interesting now, we're starting to see fungal keratitis as well. So there's a horse in Orkney at the moment that's got fungal keratitis. So I just think that's amazing, really. We used to kind of go to these meetings and listen to all these people in the south of England and stuff like that who lamented their fungal keratitis, and we were like, we don't see it. Too cold up here. These things don't happen to us. Not anymore. We have it too. And the last one I saw in Fife was about just before Christmas, but it was a show jumper that had been away and had been competing in Portugal. But this Orkney horse has never been off Orkney. It's So it's a bit scary that it's come this far north. So yeah. This one has not been, they've not had it typed yet, but the last one was Aspergillus. So, but yeah, I think the problem with it is that if you scrape it and look and find fungal hyphae, you have to treat for fungal keratitis straight away. If you send that scrape away for fungal culture, it can take 2 or 3 weeks before you get a result, by which time you've often either had a perforation or the eye's a mess, to be fair. So it is definitely, and we do get them, everybody is supposed to culture them, but it's the fact that fungal culture is so slow that it's really difficult to get them back in time. So melting, you all know about melting, you know what to look for. The most important thing about melting is that you must treat it aggressively, because if you don't, you can get a perforation early on. The risk factors for melting are brachycephalic conformation, which is the absolute top of the list by a very long way. And for us, that's a problem, isn't it? Because we still have loads of brachycephalics. And even though there was a thing, I'm trying to think where it was. Was it in the Royal College paper, or where was it the other day, saying that they think the numbers of brachyes are starting to go back down again a wee bit. And bless them, I kind of hope that's true, because I just think they just seem to get so many terrible problems, but we still see loads of them, and it's still the case that they're very appealing for people to buy, and whilst that's the case, we just have to deal with them. The presence of pathogenic bacteria and fungi, in a perfect world, you would do cytology on all your ulcers, but the honest truth is that often comes fraught with danger, because you are supposed to swab the edge of the ulcer, and sometimes it's so deep and disgusting that you think you might actually perforate the eye by taking the swab, so you've got to be really careful. Pre-existing corneal disease, this is why dry eye, so autoimmune dry eye is so important, because it's a massive risk factor for melting, and so is recent general anesthetic and sedation. So you all know that if you anesthetize or even sedate a patient, their tear film doesn't return to normal for at least a couple of days after you've done it. So for all your brachyes that have sedation and or an anesthetic, they should, in an ideal world, I mean, you all know that you're putting in lubricant during the procedure, but you should really be putting in afterwards as well, and maybe potentially sending them home with it too. So there's a cavalier that had a very long, to be fair, orthopedic SVR the other day, and they were putting lubricant all the time, and it's still got an ulcer, and 2 days later it's still got an ulcer. So, and yet they were lubricating it. I think the protocol at SVR is every half an hour or something like that, isn't it? So, and this cavalier still got an ulcer 2 days later. So, and it's an exposure ulcer definitely, because it's on the dorsal cornea, so where the eye is rolled down during the procedure, it's just the last bit of the cornea that is exposed. So, and then systemic illness. So we know that the diabetic dogs and the Cushing's dogs, if they get ulcers, are much more likely to melt. And you know what they look like once they've melted, because they'll have this kind of punched out look. So there's the edge, the ulcer there, and then this just almost looks like pupil, but in fact this is just a huge dysmetacele. So that's you looking at pupil through what is a gossamer thin bit of cornea. That's down to Descemet's membrane. This is the same. This is often the classic picture. So you get an edematous cornea, and then you get a very clear cornea in the middle. What happened there? So aggressive treatment is mandatory. Any brachycephalic should be treated aggressively. If you do see a melting ulcer, especially in a brachy, then you do need to get your clients to start giving them hourly or every 2 hours drops, so for the first 48 hours, and then you can ask them to taper. Certainly in Fife, we used to get them hospitalized quite a lot because people just thought that was too much for them to do. We tend to use Exocin, and we tend to use chloramphenicol. And the reason we use chloramphenicol is because we know that the Bt hemolytic streptococci ulcers respond to chloramphenicol, but not necessarily to Exocin. So we tend to use the two in combination. We don't use ithethal for them because we know that actually, certainly Pseudomonas is completely resistant to the effects of ithethal. And we do use protease inhibitors. So, gosh, it's quite, There you go. That's up there. Okay, good. So yeah, so on your shelves, hopefully you've got chloramphenicol. You may have some gentamicin, although we tend not to use it so much anymore. And then hopefully you've got one of these two. So you've either got siloxane or Exocin. Exocin is the drug of choice for us, and we use it in combination with chloramphenicol because we know that the two are likely to kill most of, if not all of the bacteria that are on the corneal surface. We also do antiproteases. So serum is the one that we would tend to use at the moment. So that can either be autogenous or heterogeneous, so you know that you can use serum from another dog and put it into a different dog's eye. You know that you can put cat serum into a dog's eye and dog serum into a cat's eye, and it'll have just as much effect. And we know that the antiprotease effect of horse serum is even better than it is in dog serum. So if you're in mixed practice and happen to have access to horses, then actually the serum from a horse is actually even more active than dog serum. So, and you know that if you're going to put serum in, you have to draw off and obviously either have it stand and then draw off the serum. Having done that, it has to be refrigerated, okay? So if you let it rise up to room temperature, it probably only has activity for 2 to 4 hours, at which point the rest of the bottle is inactive. So it's really important that if you have gone to the trouble of making up the serum, that you get the owners to keep it in the fridge and only bring it out of the fridge when they're putting it into the dog or cat's eye, because otherwise you don't get very much activity. We know from the work that was done in Florida that the protease activity in one of these bottles probably lasts for about 5 to 7 days, at which point you can grow bacteria in them. So the other thing is that if you're giving owners proteases, antiproteases in the form of serum away with them, they have to get a fresh bottle every 5 to 7 days, even if it's in the fridge. If you want to use something as an alternative, because sometimes getting serum is not an easy thing to do, then you can use fresh frozen plasma. Fresh frozen plasma from the blood bank is a great thing to do, and it has just as much antiprotease activity as serum. So if it's going to be an issue to you and you think that's not going to be something that you can do on a regular basis, then you can buy fresh frozen plasma. You then basically thaw it and put 10 ml aliquots into sterile dropper bottles, and then you refreeze it again, and it will last for 6 months. So if you want to have protease activity or antiprotease activity in your practice and don't have access to serum, and I always used to think when we first started doing serum, it was always pugs that needed the serum on a Friday night who just wanted to kill you anyway because they were so angry about their sore eye. And you couldn't get 10 mils of blood off them to get the serum anyway, and you were like, what are we going to do? And we were very lucky because we had a nurse that rescued greyhounds, and she would bring in her greyhound and we would take some blood off them. But actually now it's great because actually having the fresh frozen plasma is great. And the other thing that's great is Stromies. So Stromies is fab because it sits on your shelf. It's got a shelf life of 2 years or
3 from manufacturer.
3 years, yeah. So it's acetylcysteine, and it has great antiprotease activity as well. I think, if I was going to say, I think serum has slightly more antiprotease activity than Stromies, but
Kind of similar in the
yeah,
literature.
yeah,
It's about much.
yeah. I think what we like about serum is it's got growth factors in it as well, so it's got endothelial growth factor particularly. But I think that this is really good from the point of view that it just sits on your shelf. It's and you can literally be going and grabbing your Exocin and your Stromies and sending your brachy home with that, knowing that actually you're going to get your antiprotease activity early on, which is exactly what you need.
Can you freeze serum?
Yeah, you can. Yeah, so I can't really say this because we're being recorded, can I? There was a time, and I know somebody who used to freeze the serum from a greyhound anyway, but I don't know. I can't remember their name now. So what is probably not appropriate for melting ulcers is Remend, okay? So that's not, there was a thing done a while ago, and I will not go into it because it doesn't really matter, but it's just to say that even the concentrated version of Remend, the little 3 ml bottle, that's not an appropriate treatment for a melting ulcer. So you need antiproteases, and so that's why Stromies or serum or fresh frozen plasma would be enough. Treatment failure, obviously some of them do perforate. So in the case of Pseudomonas, there's an argument that up to 50% of them can perforate. So it's still the case that if you see an ulcer that's deeper than half the depth of the cornea, that you should be considering surgery on it rather than carrying on with medical treatment. So sometimes they have to come in pretty quickly. If they do perforate, then obviously it's a pretty painful event. They tend to get very head shy when it happens. Sometimes you'll actually hear them cry, starting to cry when it's happening. You may see the aqueous running down their chin. And the other thing you may well see is that you'll see a fibrin clot starting to appear in the eye, and sometimes some iris as well. So these are all ulcers that are perforated. This is thankfully quite a small one. You can see that it's got a fibrin clot just holding that perforation closed. And you can also see the little black dots, and that's iris. So that's bits of iris pigment. So when the iris bursts, the pigment comes flying forward, and you start to see bits of iris pigment appearing within the clot. If you're less lucky, you'll actually start to see blood appearing and a bit more iris. So this brown black bit here is iris in the perforation, and in this case, it's virtually all iris. So you really don't want to see that if you can at all avoid it. So if you see these, those can be grafted. So you can put a CCT in them, and they actually do really well. So even if you do see a perforation, it doesn't necessarily mean that the eye has to go in a pot. And actually, when they're like that, they actually do really well. If you see them like this, they're a bit more difficult, because if you start to see a lot of iris tissue in your perforation, unfortunately, you've got to amputate some of that iris tissue before you can actually even start to do your graft again. And you can put a two-tool patch on there, which is a scleral patch, and then put your graft over the top. But the prognosis for those eyes is not as good. So it's just, but certainly anything more than 50% depth, especially in a brachycephalic, you should consider sending for surgery, because they're the ones that need done, and probably do the best if they get done early. I've got 13 minutes on glaucoma. We can do glaucoma in 13 minutes, can't we? We'll try. So the other thing I wanted to talk about, just trying at the opposite end of the spectrum, is this, the whole idea that if you're seeing a red eye in practice, sometimes it's just difficult to say what's going on. But again, glaucoma is an emergency, and glaucoma is blinding. So we know that pressures above 40 lead to blindness. We know that if you have a raised intraocular pressure for more than 2 days at 40, then you're very unlikely to start to see return of vision, especially in dogs. Cats, for some reason, seem to be a bit more resistant than dogs to the ganglion cell death, which is what happens when you get glaucoma. And you all know that in glaucoma you get a red eye. That's just goes without saying. You tend to get a diffuse corneal edema, although in cats you don't get corneal edema, which is kind of frustrating because it makes it harder to diagnose. You see pain, ocular pain associated with pressures greater than 40, definitely. And you tend to see a dilated non-responsive pupil, so you don't have a PLR. So even if you don't have a Tonavet or a Tonapen, you should be able to make a presumptive diagnosis just based on the clinical signs. Do you all have Tonapens or Tonavets? Or yes, you do. Good. Yeah, because I think that's massive. I just think for long enough it was very unusual to see them in practice, and without them it just makes your life so much harder. And obviously every red eye should get a tonometry done regardless of the cause. So clinical signs: corneal edema, dilated pupil, episcleral congestion, acute loss of vision because those little retinal ganglion cells that run across the face of your retina just can't cope in elevated IOPs, and so they stop working, so they don't take the information from the photoreceptor to the optic nerve, which is why you lose your vision. But it's also really painful, and chronic glaucoma is really painful, which is why it's the most common reason in humans for them to request enucleation. So people really rarely request enucleation. Even if they have retinoblastoma as a tumor, they often opt for surgery, gamma knife surgery, to try and excise the tumor. But the highest instance of enucleation as a request from a human patient is following the diagnosis of chronic glaucoma, because it's just such a painful condition. And the same is true in dogs. Two forms of glaucoma. There's a primary inherited form, so unfortunately there's a number of breeds that are on the Kennel Club, the BVA Kennel Club list now for glaucoma, and so that's why they would go for eye testing to see if there's a chance that they may inherit it as they get older or potentially pass it on to their offspring. The Spaniels are probably leading at the moment, but certainly Golden Retrievers can get them too, so can Huskies and Bassets and Sharpies and a number of other breeds. And so you may well see them in your practice, and they're difficult to deal with because the problem is that often once they get glaucoma in one eye, they often go on to develop glaucoma in the other eye, and sometimes very quickly after the first one. And then there's the secondary glaucoma cases, which are the ones that are associated with lens luxation. So they're the ones that you see in terriers classically, or post-uveitis, or retinal detachment, or hyphema. This is the primary inherited glaucomas, and so if you're sending your dog to get its eye test done, this is what they're looking for. So this is a normal drainage angle here, which is the angle between the iris tissue and the base of the cornea. And this is the area through which the fluid leaves the eye. So the eye obviously produces fluid in the aqueous, in the ciliary body, and that aqueous then flows through the pupil and into the front of your eye and then escapes through this drainage mechanism here. So these little pectinate ligaments have holes between them and the fluid can leave through there. If you have the inherited form of glaucoma or the closed angle form, then this is what you see. There's virtually no normal pectinate ligaments there, and instead they've just got little flow holes like this, and eventually they block up, especially as the dog gets older. In secondary glaucomas, it just depends on the cause, but terriers are the classic ones to get secondary glaucoma, and that's because the lens tends to luxate. So the pectinate ligaments that hold that hold the lens in place tend to rupture as they get older. The lens becomes unstable, and then the lens can move forward, comes through past the iris into the anterior chamber, and then once it's wedged in the anterior chamber, that's when it causes the glaucoma. You can see glaucoma even before the lens luxates, partly because often you'll start to see vitreous starting to come round into the anterior chamber, and that vitreous that normally sits in this space here then gets into the drainage angle and starts to block it as well. So even these terriers you see that have got the aphakic crescent, where you see the lens has just moved down slightly and you can see the edge of the lens, or if you see that little grey wisp of vitreous in the anterior chamber, they may well go on to develop glaucoma long before the lens actually luxates into the anterior chamber. So it's primary lens luxation. Again, it's an inherited defect. Again, it's on the breed standards or the list for the BVA eye test. It involves pretty much all the terriers, but it also involves border collies and it involves Sharpies as well. So, and it's a bit of a pain, to be honest. If you see the lens in the anterior chamber and it has a secondary glaucoma, then the idea is you must return the lens to the posterior chamber. So without that, you'll not resolve the glaucoma. So even if you put it on treatment, it doesn't tend to resolve. So either you're going to have to couch it, which is something potentially you could do in practice, or you have to remove the lens surgically, which is something that obviously what we do. Couching is where you push the lens back through transcorneally, yeah. So there, you'll see, if you go online, you'll see the videos of how to do it. But essentially what you're doing is you're dilating the pupil, which is as wide as you can get it. So you tend to use tropicamide, not atropine, because having managed to get lens back through the pupil again, you then need to shut the pupil back down again, otherwise the same thing happens. So you, what you tend to do is you sedate the dog. You use tropicamide just to pull that pupil out as wide as possible. If that's not enough, then you can add some phenylephrine to pull it out even wider. And then having done that, you then use a gloved finger and you push across the corneal surface. You have to make sure that you don't let the corneal surface is lubricated, because otherwise you'll just create a massive corneal ulcer if you do that. So you've got to make sure, because often their cornea is quite edematous at this point, and so the idea is that you then push the lens back through. And if you get it quickly, i.e. if it's a lens that has luxated in the last 24 hours, then it should start to go back in. If it's been there for more than 28 to 48 hours, what tends to happen is the lens, there's fibrin appears in the back of the lens and it adheres to the iris, so it's really hard to get it to move. But if you can get it back through, and often it goes back through really very easily. So you've suspended the dog with its head up so that the cornea is horizontal. Having done that, you then use something to constrict the pupil. So you'd use a Xalatan or a Travatan. So any of the prostaglandin analogs, so that you can then shut that pupil down. Once you shut the pupil down, that dog then stays on Xalatan and Travatan for life. Because if you let it dilate again, it will just come straight back through. So that's couching. Having major diagnosis of glaucoma, that's any pressure basically over 25, you then have to decide which of the drops you're going to use to treat. Classically, we tend to use both sets, so we tend to use the carbonic anhydrase inhibitors, so that's the Azopt or the Truzopt, and the prostaglandin analogs. So these are the ones that reduce aqueous production, and these are the ones that increase aqueous outflow. And we tend to use the two together because they act synergistically. So we know we get a greater IOP drop if we use the two together. In an emergency, we often use them on an hourly basis, so especially the carbonic anhydrase inhibitors. Just be a little bit careful because sometimes the carbonic anhydrase inhibitors come with timolol as well, which is a beta blocker. And the beta blocker is very good at making old terriers fall over. So if they have underlying cardiac disease and you give them a beta blocker, it's a really good way of giving them a bradydysrhythmia. So just make sure that if you reach for your bottle of Azopt or Truzopt, that it doesn't have timolol in it as well, because lots of them do. And so we use them both together. If we can't get the pressure to reduce doing it that way, and it's not because we need to couch the lens, which is a totally different situation, then we would reach for either mannitol, or we would do an aquacentesis. So do you keep mannitol in your practices or not? No, fair enough, that's fine. I mean, I think, quite honestly, if you see a pressure of 50, that should be coming in anyway as an emergency. I don't think that's something that you should try and deal with in practice, because they're a pig to deal with, and to be fair, those are the dogs that will be blind, because often they come in and they've got pressures in sort of 70s and 80s, and if that's true, they're very likely to recover vision unless you get their pressure down very, very quickly. Feeling like glaucoma, it's just a bit different. The only reason I put this in at the end was because this is a cat with glaucoma. So the Burmese get an inherited form of glaucoma. So, and it doesn't help that this man's obviously strangling the cat, and therefore you all know that if you're doing IOPs in dogs and cats for that matter, you can induce a high IOP by having the owner hold it in the wrong way. So if they reduce jugular outflow, so venous return from your head, that will put your IOP up. If they over-restrain the dog's ear or pull the lateral canthus back, that also puts your IOP up. So when you're measuring pressure, it's always really important to get them not to strangle the cat or dog when they're doing it, and to make sure that if you've got a really high IOP, having done your Tonapen or your Tonavet, that you do it at least once more, if not twice more, because the lowest IOP is the most accurate. So if you do it and you're like, oh my God, it was 34, then you get whoever it is to take their hands off the cat's neck in this case, and then you do it again and find out it's 12. So it makes a massive difference. So this man actually was a breezer of Burmese. So often the only thing you'll see with feline glaucoma is that you get an isochoria, so the pupil on the affected side is wider than it is in the non-affected side, and you tend to get these really marked scleral or episcleral hyperemia. So you get this really marked increase in vessel diameter just at the limbus. And that's often your only clue that that's what's going on. These cats come with a vague history of not being very well. Nobody can work out what they're doing, and then you do their IOP, and you'll find that IOP will be very high. And often these cats, A, seem to tolerate it really well. They don't tend to get the kind of blepharospasm that dogs do. And B, they remain visual for quite a long time afterwards as well, which is remarkable. So presumably their retinal ganglion cells are much more resistant to the effects of pressure. So I think that just says the same thing. In cats, there's some suggestion that prostaglandin analogs are not effective in cats because they don't have prostanoid receptors. So in cats, you're supposed to use Truzopt or Azopt, not the Travatan and the Xalatan. I don't know why I can't spell Truzopt, but I can't. So it's just did well. Okay, that's plenty, isn't it? Oh, right on 9 o'clock. Very good.